So good morning or good afternoon, everyone. I'm privileged to be here speaking about to tell you about the SELUTION sustained Limus release drug-coated balloon, a relatively new technology that has been developed by MedAlliance. I think the first thing that we like to mention is that what is the potential advantage? Why would you consider using drug-coated balloon in coronary applications as compared to using a drug-eluting stent? As you know, and I've been involved with drug-eluting stents for so many years, and we know they work extremely well in coronary disease. But there are still a few aspects of stents that are problematic. As we know, after we implant stents in the coronary tree, there's an ongoing average 2% per year risk of stent-related events that relate to thrombosis and also recurrence of restenosis. So in relatively younger patients, the chances of having an additional procedure some years out after implanting the stent are relatively high. This is a paper published by Greg Stone recently that did a pooled analysis of 25,000 patients in 19 stent randomized trials showing this ongoing risk. And I think we have the opportunity to reduce long-term events by treating some lesions with drug-eluting balloons as compared to stents, especially in small vessels, complex lesions, diffuse disease, and a topic of today's discussions, bifurcations. So we think there's a potential developing new paradigm of in a large number of coronary patients where we can actually preserve arterial physiology, in other words, vasomotion, by applying a drug-coated balloon instead of a stent scaffold, which will allow for positive remodeling and avoid scaffold complications such as inflammation, long use of dual antiplatelet therapy, a potential for stent fracture, and in some cases avoiding a full metal jacket. So using a drug-coated balloon can keep the patient open for future interventional procedures more readily than a stent. So as you know, if you're working in the coronary space, sirolimus has largely replaced paclitaxel as an anti-restenotic drug because it's a cytostatic drug. It has a wide margin of safety. But most importantly, the late loss, lower late lumen loss, the anti-restenotic efficiency of sirolimus has been established in coronary trials to just be better than the use of paclitaxel. So you can see here some of the trials that have been done that established that sirolimus stents were better than paclitaxel in the field of drug-eluting stents. So our goal with designing a sirolimus-eluting balloon was to enhance tissue absorption because sirolimus is not as readily absorbed into tissue as some of the other anti-restenotic agents like paclitaxel. And so we had to develop some kind of a way of applying, if you will, an instant glue that would allow the drug to be adhered to the vessel wall during this relatively short procedure involved in deploying a drug-coating balloon. We wanted to extend the tissue retention time because we knew in order to allow sirolimus to really be effective, we had to have a pharmacokinetic profile that was at least comparable with what we get when we implant a drug-eluting stent. And as we know, the drug-eluting stents, the coatings are capable of releasing the sirolimus over a 30 to 60-day period in order to exert the anti-restenotic effect. If we just coat sirolimus on a balloon without some kind of a time release mechanism, we would have a very poor result. You need an extended release of the drug in order to have to cover the entire anti-restenotic cascade. And finally, we wanted to use a non-crystalline form of sirolimus because the crystals tend to be very rough. The surface of the balloon becomes quite irregular. It makes the balloon tracking much more difficult. It does more injury to the vessel wall. And there's a lot more potential for wash-off and embolization of the drug when you're using some of these first generation coatings, such as a contrast medium to really apply the drug. So we really required the development of a whole new coating system, which we call a cat membrane, which I'll talk more about. So the first step was to combine the sirolimus with the biodegradable polymer, very, very similar to what you would find on the surface of a drug-eluting stent that contains a biodegradable coating. And this took the form of these small microspheres that you see on the right-hand panel. They're 4 microns in diameter, and there's literally millions of them that are created and placed on the surface of the balloon, each one of them comprising a miniaturized drug delivery system that's capable of releasing drugs over a 60 to 90-day period. That is then combined, the microreservoirs are bathed in a cell-adherent technology. This is an absorption enhancer, which increases the delivery efficiency of the sirolimus into cell membranes, which is based on amphipathic lipid technology, which was developed by MedAlliance specifically for a new generation of drug-coated balloons. And then this is just a movie showing you the animation of how the combined system works with the microreservoirs, the biodegradable polymer and drug, combined with the cat coating, which enhances the delivery. As we expand the balloon, the cat coating carries the microreservoirs to the vessel wall, where they're able to be embedded and released over a period of up to 90 days. This is basically different than you find with other drug-coated balloons that are using relatively less sophisticated coatings that are basically burst release application of the drug. So in this example, compared to some drug-coated balloons that were developed for the vascular treatment of vascular disease, you can see that on the left panel we have a much longer drug release out to 60 days, still maintaining adequate therapeutic effect in this animal model. You see on the left, compared to the other systems where the drug is relatively lost over a 28 to 30-day period. And then, of course, we can, because of the relatively constant release of drug, we can actually go to a much lower dose of drug overall, because the importance is the timing and the release of the drug, the pharmacokinetic profile, not necessarily releasing a large amount of drug early, because when you release large amounts of drug, it's just lost to the interstices between cells. There's only a certain number of drug molecules that can reach inside and reversibly bind to the immunophilins that are actually playing a role in cell multiplication. So here's just some pictures of a coronary pig artery that's been implanted with a sirolimus-eluting balloon, the solution. And you can see these colonies of microspheres that are actually inhabiting the surface of the vessel wall, where they continue to release drug and biodegrade over a 60 to 90-day period. So here's the drug concentration pharmacokinetic profile, and what I want to point out to you in the green is the actual pharmacokinetics of solution is very close to what you would get with a currently available, commercially available drug-eluting stent. So our goal is to get a pharmacokinetic profile that we also see when we implant a highly clinically successful drug-coated stent like the Xience. So in essence, you get the same pharmacokinetics as you get with the Xience stent, but without the metal scaffold. This is quite a bit better than you see with other competing sirolimus-eluting balloons that are available today. So why does sustained release really matter? Well, it all has to do with the restenotic cascade, which was actually published by Forrester back in 1991. When you do angioplasty, first you get a platelet deposition in the injured area, followed by inflammatory cell recruitment over a 1 week, 3 day to 1 week period of time. And then you get the actual smooth muscle cell activation and proliferation into the area of the angioplasty. And finally, you get matrix formation which actually lasts for an extended period of time after you've done your interventional procedure. And so we really need to have drug release over this entire period, not just over the first 30 days, to have the best effect on controlling restenosis. So this is just a picture of what happens in the peripheral arteries, where actually the healing process is even longer. And so in other applications where drug-coated balloons are being used, we also need a very extended release of the drug in order to deal with the smooth muscle cell proliferation and the ECM formation that goes on for extended periods. You may recall the Endeavor stent, which was a Limus-coated stent which was unsuccessful in terms of controlling restenosis. And you can see the pharmacokinetic profile of Endeavor was just too fast. And that's why it did not continue to provide an extended release of drug over an adequate period of time to really treat the entire anti-restenotic cascade as described by Forster. Whereas the more successful clinical designs of drug-eluting stents today have an extended release that lasts at least 30 days. In the case of a stent that I designed, the MyoMatrix, the release that lasts up to 90 days. And it's been a very successful design going out and treating patients. So the microreservoir technology produces a coating which is very smooth and supple. And I think this is one of the very important side advantages of using these new lipid-based coatings that we use on solution. It doesn't create these large flaking particles that can go downstream and embolize into the downstream coronary vascular beds. And this results in an absence of this phenomenon that we often see, which is called slow flow, where you see of these large particles going down and actually being trapped in vascular beds and causing some changes in downstream coronary pathology as a result of the presence of these large particles. So I'm just going to interest in the time saying that microreservoir technology is extensively used in other areas for delivering drugs that need extended release in other applications such as cancer. And it actually improves the drug stability in an aqueous environment, and it shields the drug from being washed away during delivery to the target tissue. And it's often used with highly toxic drugs that need to be released slowly. So microreservoir technology, as we've now first applied in drug-coated balloons, is not a new science. It's actually been well established in other applications. And I'm going to just move on and say that I think the coating technology that we're using is better, and I think more companies will be moving to these lipid-based coatings. So the Solution SLR was first tested in coronary in a Solution SLR first-in-man trial, which was reported by Dr. Windecker at the European College meeting. The objective of the trial was just to show that the sirolimus as delivered by the balloon was efficacious with short depth of 1 month, and looking for all the secondary safety endpoints at 6 and 12 months for freedom from TLR and TVR. Lesion types were large preponderance of small vessel, 24%, 31% bifurcations, 4% CTOs, and importantly, 84% of these in this first-in-man trial were de novo lesions, 16% were ISR. There were no deaths or MIs through 30 days and 1 TLR at 6 months in this first-in-man study. So the primary endpoint was met of freedom from device and procedure-related mortality through 30 days. If you look at the Kaplan-Meier curve for late lumen loss, we had a very acceptable performance. At follow-up, the Kaplan-Meier late loss figures were very close to the results that were obtained post-procedure, and much better than the pre-existing diameter of the vessel. Here's also the diameter stenosis. I've seen pre-67%, dropping to 22% post-procedure and 30.5% at 6-month follow-up. In terms of mean late loss, we can see a very nice distribution of low late loss, the average being 0.26. And we had one outlier, which had to do with a lesion that was treated with both paclitaxel and sirolimus, which created the TLR. We're not sure why both kinds of drug-coated balloons were used, but ended up not being a good solution for this particular patient. So we're continuing with our studies. We know more data is needed with the SELUTION first-in-man trial. It's a de novo trial in Asia, which has been completed at 12-month follow-up. We are looking at longer time periods. The SELUTION ISR is a FDA trial to look at using sirolimus drug-coated balloon in the setting of in-stent restenosis. The SELUTION de novo, which is a large trial, 3,300 and some patients in both Asia and Europe, which we're very excited about because we think that drug-coated can replace drug-eluting stents in the coronary de novo applications. And finally, there's a similar trial with the FDA, which is an international trial in Europe and the US that is being reviewed by FDA currently. So we hope you'll learn more about the unique technology embodied in the SELUTION drug-eluting balloon through the following talks. I'm excited to be part of this presentation, and I'm going to turn it back to the moderator and the other speakers to talk about some of the specific applications that they're excited about. Thank you very much for your time.
Thank you, John. Very interesting. Before we move to maybe questions from my colleagues here, I have one very technical question. You know, sometimes the balloon does not cross, and then you have to come back and then push again, and then come back and push again. How much drug do we use if we have difficulty in delivering the balloon to the target lesion with the SELUTION now specifically?
So with drug-coated balloons, and this comment is general to all drug-coated balloons, if you have significant difficulties delivering to the lesion, in other words, the lesion is tight or highly tortuous, and you're not able to deliver it within a time period of several minutes, I would recommend taking a new drug-coated balloon. The coating on the SELUTION is relatively robust. We've done a lot of testing to make sure that it's not easily dislodged. And I think it's one of the better coatings in that regard, but there is certainly potential for scraping off the coating in the presence of a lot of calcium, a lot of tortuosity. So I think if you incur a lot of difficulty and you can't deliver it in a certain time period, it's not because the coating is washing off, but certainly mechanical disturbance of the coating is possible.
Okay, thanks. So are there any questions from the faculty, from the presenters?
There's one more question from my side regarding the coating. How do you do it? You basically inflate the balloon and then coat it and then deflate it and fold it, or do you have a folded balloon which gets coated?
Yeah, it's inflated so that the entire surface of the balloon is exposed, and then it's put into a fixture that rotates, and we coat the entire balloon. So the folds are also coated inside. Excuse me.
I would like to comment only that you stressed two weakest points of the drug-coated balloons in your technology. One is drug loss during the delivery. And we know that there are many balloons from the leaders of the drug-eluting balloon technology that you can lose as high as 80% of the drug during delivery. So it is, you are delivering just little something in the end. And as Florim said, even if you have additional difficulties in delivering the balloon, you are delivering just the plain balloon. That's the most important, I think. And the second thing that is, in my opinion, the breakthrough is the long-lasting release of the drug in the place of angioplasty or in the place of damage, because that's what we believed up to now. We believe that we should give small dose or big dose of the drug, but for the short period of time. Because we believe that, okay, we should stop the proliferation of the smooth muscle cells to prevent restenosis, but we haven't, we cannot stop the endothelization of the place of angioplasty because it gives, it also stops the proliferation of smooth muscle cells through the release of the nitric oxide. So this is breakthrough of the technology, because you are giving the long-lasting, small amount long-lasting of the drug, which goes to the smooth muscle cells, not stopping the proliferation of endothelium. So can you comment on that?
Yeah, so we learned well from our 30 years experience with drug-eluting stents that the drug-eluting stents endothelialize more slowly as compared to a non-coated scaffold, because the presence of the drug actually slows down the repair mechanisms that are natural to the artery. The drugs, whether it's sirolimus or paclitaxel, do slow down endothelialization. They do slow down at the same time that they're preventing smooth muscle cells from proliferating. So these drugs act on both endothelium and on the smooth muscle cells. So sirolimus in that regard seems to endothelialize better because it's less toxic, but there's still some slower action. So that's why it's important during that initial period of, I would say, at least 30 days to still have some kind of antiplatelet therapy on board, because we're slowing down the repair of the vessel by using drugs.